The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/CSW860. Downloadable slides and practice aids are also available.
Hello, and welcome to Fueling Innovation in Multiple Myeloma. I'm Dr. Sagar Lonial from Emory University and the Winship Cancer Institute in Atlanta, Georgia. During this presentation, we'll assess some of the evidence that has continued to inform the modern practice of myeloma management, and also discuss some recent updates from the virtual ASCO conference. So, as we know, there have been a lot of changes in multiple myeloma over the last few decades, and making sense of some of these rapid changes certainly does become a little bit of a challenge. We know that in the earlier parts of the last decade, we saw the approvals of next-generation PIs and IMiDs like Carfilzomib, Ixazomib, and pomalidomide, as well as new monoclonal antibodies such as Daratumumab and Ilotuxumab, HDAC inhibitors like Panobinostat, EXPO1 inhibitors such as Selinexor, and we saw the emergence of MRD assessment being added to the NCCN guidelines. But more importantly, in 2020 and beyond, we've now got new second-generation anti-CD38 antibodies such as Isotuxumab. We've got BCMA-directed approaches such as antibody-drug conjugates, bispecifics, and BiTEs, and we have CAR T-cells, as well as other novel targeted agents such as venetoclax and new third and fourth generation immunomodulatory agents. So there are a number of questions that we're going to discuss in the next few moments that really relate to some of these new drugs trying to supplant some of the old ones, and what is the randomized trial data we have in each of these situations, whether it's newly diagnosed myeloma, quadruplet-based induction, antibodies in relapsed and refractory myeloma, or cell therapy options moving forward. So let's start off with a discussion on primary therapy. Should RVD remain the standard induction for patients with newly diagnosed multiple myeloma? We know that in the NCCN guidelines, there are a couple of options that are recommended with level 1 evidence. The first is RVD. The second is VCD, which I'll be perfectly honest with you, is one of my least favorite regimens to be used in newly diagnosed myeloma. And then the European version of VRD, which is VTD, bortezomib, thalidomide, and dexamethasone. We know that transplant continues to remain an important option for patients. And then in the maintenance setting, lenalidomide and or Ixazomib are category 1 options as well. So what do we know about non-transplant eligible patients? Well, there are a number of different options. Again, RVD continues to remain an important option. We know from the first trial, as well as Maya, that Dara plus Lendex is now category 1. Len-Lodos Dex is category 1. And again, VCD comes in again, though again, my personal preference is not to use cyclophosphamide-based inductions for newly diagnosed myeloma. There are other approaches, such as Dara plus bortezomib, melphalan, and prednisone, that in the U.S. really don't get a lot of play. And again, in the maintenance setting, lenalidomide is a category 1 option. There is emerging data for the use of Ixazomib in the non-transplant eligible patients as well. So one of the most important abstracts I think presented at ASCO this year was the phase 3 endurance study. And this was a large randomized phase 3 trial from the ECOG group, also known as E1A11. And in this trial, there were really 2 randomizations, and what we're going to focus on is that first one because it's probably the most relevant. So there was an initial randomization of patients to receive VRD, bortezomib, lenalidomide, and dexamethasone, versus KRD, the replacement of bortezomib with Carfilzomib, as well as lenalidomide and dexamethasone. And this trial was really based on the idea that there were a number of phase 2 studies that were relatively small that suggested that KRD might have a better depth of response and may have more durability than VRD in the newly diagnosed multiple myeloma setting. And based on that, this endurance trial was initiated. There was a second randomization to maintenance and whether patients received maintenance until progression or maintenance for only 2 years. And that randomization is not really addressed in this initial presentation. Now, what we saw at ASCO this year, Dr. Kumar presented this as a plenary talk, was that if you look at PFS from initial induction randomization, there was absolutely no difference between RVD or KRD. They were basically the same. With a median follow-up of about 15 months, we've hit the median PFS now, somewhere around 30 to 36 months, as you can see here, and there was really no difference at all between the two arms. It's also important to realize that even for patients who were older, that there was perhaps a slight advantage for RVD with 37-month PFS compared to only 28 for the KRD. And again, if you begin to look at response rate, every other measurement that was looked at in this phase 3 trial was basically identical between RVD and KRD, suggesting, again, not major differences overall. If you begin to look at adverse events in this trial, what you'll see is the frequency of grade 3 adverse events was relatively similar, about 48% versus 52%, slightly higher with KRD, but I don't consider that to be really significantly meaningful. And again, if you look at non-heme adverse events, relatively similar if you look at grade 3 or higher, 40% versus 37% in both of those two arms there. Now, if you look specifically at adverse events of interest, we can look at cardiac, pulmonary, and renal adverse events, knowing that this is a concern with Carfilzomib. And as you can see, there was a higher incidence in aggregate, 16% versus 4%. If you look specifically at grade 3, 12 versus 4%. And then grade 4 was also slightly higher, but really it's the grade 3 or higher that seemed to be the biggest difference. Now, if you flip that and then look at peripheral neuropathy, you'll see 53% of patients in the VRD arm had some level of peripheral neuropathy compared to only 24% in the KRD arm. And if you look at grade 1, grade 2, that was clearly the majority, 45% versus 23%, with only 8% in the RVD arm developing grade 3 or higher peripheral neuropathy. So I think that this is really an important randomized trial because there certainly are a number of different camps out there talking about different induction therapies. And what we see from the large, over 1,000 patient randomized endurance trial is that at least on the surface, with the quick endpoints of PFS, response rate, adverse events, there appears to be no real difference between these two, suggesting that RVD continues to remain the standard for these older or younger patients with newly diagnosed myeloma. Now, we know that triplets certainly are an important part of the discussion, but the field is now moving beyond triplets into quadruplets. And we have a number of studies that evaluated this question. The first was the Cassiopeia study that was published in Lancet last year, looking at VTD versus VTD plus daratumumab. And what we see now, again, in that original paper, was that the depth of response was clearly higher for the addition of daratumumab, and that responses deepened over longer periods of time. If you begin to look across in terms of summaries with MRD negativity, what you see is 64% of patients achieved MRD negativity in the DARA arm compared to only 44% in the VTD arm, including all subsets and high-risk patients. But I will point out that this was measuring MRD negativity at 10 to the minus 5. And personally, I'm not convinced that 10 to the minus 5 is the right endpoint, particularly if we're going to talk about discontinuation approaches in the context of multiple myeloma. Now, if you take that first trial and begin to look at PFS from first randomization, there is a clear, definite difference in PFS, 93% versus 85% for the group that did not receive daratumumab, with a hazard ratio of about 0.47. However, to me, what's really quite intriguing about this is there was a second randomization in this trial to daratumumab maintenance versus no maintenance at all. And that began somewhere around the 9-month mark. And if you'll notice, these two curves begin to separate at or around 9 months. And so I think using PFS in this trial, where DARA was randomized to DARA versus observation at an early time point, makes using PFS in this trial a little bit more challenging. And there certainly are other trials that are asking what I think are fairer questions in the maintenance setting that allow us to build on the addition of daratumumab to early initial induction therapy. And I think one of the better trials that is doing this is the Griffin trial. And as you can see here, Griffin is a randomized phase 2 trial looking at RVD in both arms with the addition of DARA in one group versus no DARA in the other. And what I think you see here again is that recapitulation of deeper responses, more CRs, more MRD negativity in the group that received DARA compared to the group that did not receive DARA. And the difference here is that everybody received reasonable consolidation and maintenance after the transplant, allowing us to really tease out the PFS benefit of adding DARA early on into the treatment approach. And this, to me, again, is something that our group has adopted as an initial induction strategy, using RVD DARA for standard risk newly diagnosed myeloma for the first 4 cycles of induction therapy. So this, again, is out there and was updated at the ASCO meeting. Now, what about adding a different CD38 antibody in? This is data from the European group adding in Isotuxumab with KRD in newly diagnosed myeloma. Again, a relatively small phase 2 study of 50 patients. 100% achieved a PR or better. If you look at VGPR or better, 90% in the ISA KRD arm. And again, MRD and assessment suggests that 20 of 33 patients were MRD negative, 11 patients were MRD positive, and only 2 at this point were non-assessable. So this again suggests that ISA plus KRD using a different anti-CD38 antibody may give you very good results. The question is it the same as if adding ISA to VRD? We know VRD and KRD appear to be relatively similar, and I guess the question is, are ISA and DARA really appreciably different in the newly diagnosed myeloma setting? And we don't have that answer. So I think some of the take-home messages with new approaches to primary therapy. From Endurance, we've learned that at least the way this trial was designed, KRD is really no different from VRD. It's important to notice that both arms received twice-weekly dosing of both bortezomib and carfilzomib in that trial. There are a number of trials looking at once-a-week bortezomib and a number of trials looking at once-a-week carfilzomib, suggesting efficacy is similar between once-a-week and twice-a-week carfilzomib. And so approaches to try and improve convenience are certainly ongoing, but on the surface we have no clear way to differentiate between VRD and KRD other than differences in adverse events. And more importantly, antibody-based quadruplets I think are here and ready for prime time in certain subsets of patients. As I mentioned, our group has already adopted the use of VRD plus DARA for newly diagnosed standard risk myeloma. Our approach is to use the DARA in the early 4 cycles of therapy and then not use it in consolidation and maintenance until we have greater follow-up on those trials, demonstrating the benefit of adding DARA in the maintenance and consolidation phase. But we certainly do believe that early deepening of responses with DARA will translate into better long-term outcomes for patients, and that is important, particularly in those first 4 cycles of therapy. So let's move on now to antibody platforms in relapsed and refractory multiple myeloma. What we know is that there are some new trials and new data that help us to use the tools that we already have in better and more patient-friendly ways. And the first trial that really addresses this is the Columba trial, the phase 3 non-inferiority comparison of SubQ versus IV daratumumab in relapsed and refractory myeloma. And what we know right now is that in May of 2020, the FDA actually approved the SubQ preparation of daratumumab. And in what I think is a real credit to Janssen and their colleagues, they've actually not increased the price for a 70-kilo patient for the SubQ versus the IV. And so I think it makes it relatively easy to say anybody that one might consider IV daratumumab for, making that switch to subcutaneous is certainly a reasonable switch because it is certainly a lot more patient-friendly. That first dose, the observation period does continue to be long, but beyond that first dose, patients can get in and out of the clinics and the offices much quicker with the use of SubQ daratumumab compared with IV daratumumab. And what you'll see here is the response rates are basically the same, perhaps slightly better for the SubQ, but likely statistically are the same. And in fact, the frequency of adverse events as measured by infusion reactions are appreciably lower with the SubQ administration compared to the IV administration, making this what I think is a relatively easy and standard approach for patients in all settings where daratumumab may be considered. Now, we also saw data at ASH this last year about the Candor trial, which is carfilzomib, daratumumab, and dexamethasone versus carfilzomib and dexamethasone. And what I think you see here is a significant improvement in progression-free survival, favoring the triplet over the doublet. This is pretty marked. Again, what you see here in terms of the difference in terms of PFS between the two arms, not reached for the group that received KPD or KDD compared to 15.8 months for the CAR-Dex arm, with a hazard ratio of about 0.6. And I think this again gives us another potential alternative approach for patients who are progressing on lenalidomide maintenance. We know that pomalidomide-based backbones and triplets are certainly very effective. This is now beginning to give us carfilzomib-based triplets. And what I really like about this one is that the carfilzomib dose is likely at the most effective dose of CAR, which is 56 milligrams per meter squared given twice a week. There's no question in my mind that that does represent one of the more potent doses of carfilzomib, and the challenge in carfilzomib combinations is being able to combine that dose with other drugs. What we see very nicely here is that DARA is easily combinable with that higher dose, and that triplet-based approach translates into deeper, durable responses for patients with a higher overall response rate, VGPR or better, CR or better, and MRD negativity rates that are almost 4 to 5-fold higher, again, only at 10 to the minus 5, but certainly higher at 12 months compared to the doublet of carfilzomib and dexamethasone. So in this setting, I think it becomes a very meaningful and important possibility. Now, we've early talked about once a week versus twice a week carfilzomib, and this is some data comparing Candor at twice a week dosing of carfilzomib with the Equalis trial using weekly dosing of carfilzomib at 70. What I think you see is that the response rates are somewhat similar, 83 versus 82, 79 versus 81, and that at least it looks right now like the PFS rates are somewhat similar, suggesting that carfilzomib given at a once-a-week dosing may be as effective as the twice a week, but the dose is higher at 70 milligrams per meter squared given once a week. This is certainly a reasonable thing to consider if convenience is important to the patient. I personally like to go with the 56 twice a week in the beginning, just to make sure that we've maximized exposure to the drug and maximize the chance of response, and then potentially cut down to a once-a-week dosing once we know that this combination is effective. But there are a number of different strategies that I think are reasonable and appropriate to use in this clinical situation. Now, what about Isotuxumab? Isotuxumab is a different CD38 antibody. It binds to a slightly different epitope on CD38 than daratumumab does, and it has a number of both tumor and immune-based effects that may be slightly different. One of the key differences with Isotuxumab is its ability to modulate the ectoenzyme effects of CD38 that daratumumab does not necessarily do to the same level as we see with Isotuxumab. And whether that translates into a real change in functional activity is unclear. But what we know right now is that Isotuxumab, when combined with PomDex, is clearly superior to PomDex in a randomized phase 3 trial. And this is the ICARIA trial that again asks that very same question. Can we use Isotuxumab plus PomDex in blue versus PomDex in gold here? And is there a difference? And as you can see, overall response rate, depth of response, and PFS are clearly better for the triplet versus the doublet, almost a doubling of the PFS in a more heavily pretreated relapsed and refractory myeloma patient population with at least 2 prior lines of therapy. So this is not a first relapse trial. This is likely a second or beyond relapse trial, and that's why the PomDex arm has done so poorly in my view, only 6 months, although that is better than the 3-month median PFS that we often see for PomDex as a control arm. And this, to me, again, establishes the role of Isa-PomDex in relapsed and refractory myeloma. What you see is the response and depth of response clearly higher, VGPR or better, almost 4-fold higher for the Isa-PomDex compared to PomDex up here, And again, those translated into meaningful benefits and improvements as measured by PFS. Now, another subtle endpoint that was looked at in the ICARIA trial was renal improvement in renal function. And as you can see here, there were more patients who had significant improvement in renal dysfunction for the ISA-POMDEX compared to the POMDEX group here. 32% versus 21, 71% had a complete renal response compared to only 38% in the POMDEX arm, and sustained renal response was almost double for the group that received Isotuxumab, suggesting that this is really translating into significant benefits. And if you look at what the cost of that was from an adverse event profile, you can see infusion reactions were relatively low and rare. Most of them were grade 1, grade 2, and occurred early on. There was only a few grade 3, grade 4 infusion reactions, so not a high issue overall with Isotuxumab. And if you begin to look at all adverse events across the board, slightly higher rates of infections, not a surprise. Similar things are seen with daratumumab, but again speaks to the role and efficacy of a CD38 antibody in combination with pomalidomide and the true benefits of a triplet versus a doublet in the relapsed and refractory setting. So again, when we talk about take-homes with new evidence on antibody platforms, there really are a couple of important take-home points, I think. The first is Columba has clearly demonstrated that SubQ DARA is here to stay. It was FDA approved just a few months ago, and I think that given the efficacy, the safety, and now what we see is really favorable cost data, there is no reason to think about not substituting it pretty much anywhere one would want to use IV DARA, because it does make it, the patient experience significantly better. We also see combinations of DARA with Carfilzomib demonstrating significant efficacy, and that efficacy I think is really important because it gives us another option for patients that are progressing on lenalidomide maintenance. It gives us a PI-based option that clearly has very long progression-free survival and gives us another option using a very potent PI at full dose in combination with daratumumab. And finally, we see the emergence of a new anti-CD38 antibody, Isotuxumab. We saw data from a phase 3 randomized trial combining with POMDEX, suggesting that ISA-POMDEX is now a new standard for patients where POMDEX was considered useful, and that this triplet is clearly very active and effective, particularly in patients who are progressing on lenalidomide maintenance. And so I think as more and more patients are on len maintenance, POM and Carfilzomib-based combinations become increasingly important, and now we've added to the armamentarium of phase 3 trials that give us real treatment options for these patients. So let's move on now and talk a little bit about BCMA, both antibodies and CAR T-cell based therapy in relapsed and refractory multiple myeloma. And we know that BCMA is a target that is likely the far superior target of any potential antibody in multiple myeloma, because BCMA expression is limited and almost highest expressed on the mature plasma cell. And that allows us to really be a little bit more surgical, if you will, when we think about using an antibody or a CAR T-cell or a bispecific based approach in the management of myeloma. BCMA, again, is much less heavily expressed on other target tissues, making BCMA, in my mind, an ideal target. Now, the first agent I'm going to talk about is belantamab mafodotin, or Belamaf. Belamaf is an antibody drug conjugate. Along with it is associated a toxin called MMAF. And what we know about MMAF is that it's a highly potent chemotherapy drug, and its use in myeloma can not only directly kill the cell, but can also induce immunogenic cell death. And Belamaf was actually demonstrated in the DREAM-1 study to have significant activity with a 60% response rate in a slightly earlier relapsed and refractory patient population. I then recently published a phase 2 study called the DREAM-2 study that was published in Lancet Oncology that demonstrated roughly a third of patients with a median of 7 prior lines of therapy could respond to Belamaf. And what I presented at ASCO this year was an update of the duration of response data from DREAM-2. And what we see is that using the lower dose of 2.5 milligrams per kilogram, that the median DOR is about 11 months. And so this 30% response rate with an 11-month DOR now puts it as one of the most active agents in the refractory myeloma setting. Clearly in the same league as daratumumab in that same situation a few years ago, Carfilzomib, or other drugs that were tested in a refractory myeloma patient population. The exception, of course, being that everybody enrolled on DREAM was resistant to Dara and resistant to Carfilzomib and resistant to many of those other agents that were approved a few years ago. So this data really sets the stage for some of the important activity we're going to see targeting BCMA in multiple myeloma. Now, at this meeting, my colleague Dr. Nuka presented an update on the DREAM-6 trial, which is combining bortezomib with belamaf and dexamethasone. And what he showed was that the response rate was clearly higher. It was in the 70s in a relapsed patient, a slightly earlier relapsed patient population, and that the incidence of infusion reactions and keratopathy and thrombocytopenia does appear to be slightly lower in this earlier relapsed patient population, and that it was in fact safe and efficacious to combine belamaf with bortezomib. And we'll see more data on this trial going as we see additional trials coming forward. Now, what about CAR T cells? This is certainly a big, exciting area for all of us in myeloma. We've been a little bit behind our lymphoma and ALL colleagues in getting a CAR T cell to market, but we saw data at ASCO this year from the KarMMa-2 study, the phase 2 KarMMa study, which uses the cell therapy BB2121 or ide-cel. And Dr. Munshi, one of my colleagues, presented data on this, where patients were, again, refractory myeloma with a median of 6 to 7 prior lines of therapy, resistant to IMiDs, PIs, and anti-CD38 antibodies, underwent leukapheresis, then were allowed to have 2 weeks of bridging therapy, then received Flu/Cy lymphodepletion and infusion of CAR T cells, and were monitored and treated similar to other CAR T cell technologies that many of you all may be familiar with. Now, there were a number of doses that were tested in the KarMMa trial, 150, 300, and 450 times 10 to the 6 per kilo. And what I think you'll see here is that the 450 dose clearly was the most effective, with about 39% of patients achieving CR. And in fact, if we began to look at durability of response, the median PFS and DOR was about 11 to 12 months, suggesting that with just one infusion of cells and no additional therapy, patients could get very long and durable responses, and that some patients actually did achieve MRD negativity. And this is certainly very important and exciting as we think about treatments in the refractory myeloma patient population, where there really are very few treatment approaches that are effective at all. If you begin to look at cytokine release syndrome, or CRS, you can see the incidence of all CRS is about 50 to 90% here, but most of that was grade 1, grade 2. Very few patients had grade 3, grade 4 CRS, suggesting that CRS in the myeloma patient population is in fact quite different than what we see in ALL or lymphoma, where the grade 3, grade 4 CRS rates are much higher. Additionally, we know that the neurotoxicity is also much lower with BCMA-directed CAR T cells than what's seen in either CD19-directed treatment in ALL or B-cell lymphoma. And I think this is really an important and exciting way for us to safely deliver this therapy in a group of patients that really are very heavily pretreated and often carry significant comorbidities. Now, another trial that was presented at ASCO by my colleague Dr. Berdeja was the Cartitude-1 trial. This is also known as J&J 4528. This is basically taking the L-CAR construct from China and bringing it into U.S. As part of a U.S. manufacturing approach. This does target 2 different areas on BCMA, and so might be functionally different than what we've seen with BB2121. What we saw at this data was a 100% response rate in an N of only 29 patients, but stringent CR of 86%, and again, all were relatively resistant and refractory coming into treatment, suggesting that this is a really important and effective treatment. And what we really need is longer-term follow-up and larger patient numbers to truly appreciate the differences between these different CAR T-cell constructs going forward. So additional take-home messages for BCMA and myeloma. I think this is going to be the next big target in myeloma. BCMA is more specific than CD38 or SLAMF7. We have lots of different ways to target BCMA that include antibody drug conjugates with belamaf, which will hopefully be approved in the next year, CAR T-cells, which will hopefully be approved in the next year, and bispecifics or BiTEs. Those are coming. There was data at ASCO suggesting significant efficacy and activity, and we're certainly excited about some of those moving forward in the field very soon as well. And again, the advantage to BCMA is that it's far more specific for plasma cells, allowing us to have perhaps less off-target effects and less effects on general immune function than we see with either CD38 or Isotuxumab. Now let's move to the last target we're going to talk about in this session, and that's targeting EXPO1. And we know that selinexor is a drug that was approved last year to treat refractory multiple myeloma. The combination that was used there is selinexor and dex. And the real mechanism is actually somewhat quite unique in the sense that EXPO1 is responsible for trafficking of oncogenes or other proteins in and out of the nucleus. And by arresting and preventing that translocation, we may have a significant impact on movement and translocation of those proteins across the nuclear membrane. We know that selinexor plus dex clearly has activity in patients with relapsed and refractory myeloma. And what we saw at ASCO this year, as presented by Dr. Dimopoulos, was the phase 3 Boston trial. And what this tested was selinexor plus bortezomib and dexamethasone versus bortezomib and dexamethasone. And what we saw here was a significant improvement in progression-free survival for the triplet arm, 13.9 months, so almost 14 months, compared to 9.5 months for bortezomib and dexamethasone. And remember, this was using bortezomib weekly in the triplet arm and twice a week in the doublet arm. So I think this really is an important step forward for us and gives us a really safe and important way to use selinexor, particularly if you begin to look at adverse events. Again, triplet versus doublet, what you see here is that the GI toxicity that we often see with selinexor significantly lower in the triplet, suggesting that using the lower dose in combination with bortezomib has a significant reduction in terms of GI toxicity, fatigue, asthenia. All of this was lower in the grade 3, grade 4 category, suggesting that this really is a major step forward for patients and perhaps a preferable way to help us deliver selinexor as part of a triplet-based combination. So I think in conclusion, what we've seen is that there was the huge different approaches to managing patients with myeloma in each of the different phases of treatment that we commonly see. In the newly diagnosed setting, we've learned that really VRD and KRD are basically equivalent from a large 1,000-patient randomized phase 3 trial. But the question is, can we move beyond an IMiD-PI combination with the addition of antibodies, whether it's Isotuxumab or daratumumab? We have convincing data on depth of response. We need longer follow-up and larger trials to help us understand the impact of an anti-CD38 antibody in the maintenance and consolidation phase, but early on there seems to be significant benefit from early therapy. We saw in the relapse setting the emergence of SubQ daratumumab, which is really a major step forward for our patients, and more importantly, new options for patients presenting on lenalidomide or progressing on len in the early relapse setting, combining with Carfilzomib or combining with pomalidomide to try and overcome len resistance and get patients back into remission again in the first relapse setting. And finally, we wrapped up with BCMA-directed therapies with belamaf as an antibody drug conjugate with 2 different CAR T-cell constructs, as well as with selinexor in combination with bortezomib. And I know we have a number of other emerging targets that are coming as well. So again, the world is really quite exciting in myeloma. We have many new targets, many new drugs. Figuring out how to put them together in the optimal sequence to increase the cure fraction represents an important goal for us. And I think that that's a challenge that we're all willing and excited to take going forward. Thank you for joining me, and I hope you found this program useful for your practice.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/CSW860. This educational activity is supported by educational grants from GlaxoSmithKline, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Sanofi US.